So I understand this talk is not the highlight of this session because, we're in an interventional meeting. So risk stratification is not something that is very exciting, but try to be quick, I understand. We have more exciting talks after this. But we've all seen pictures like this circulating in the internet and social media demonstrating how heavy burden PE clots can be. And when you're faced with this, you wonder what's the best way to manage. And we know that PE is a known killer. It usually does so by creating an RV failure due to the acute pressure overload. And pulmonary pressure can go up to 30–50% of its total cross-sectional area if it's occluded by thromboemboli. And the clinical symptoms and signs of overt RV failure indicate the high risk of early mortality. So when we talk about how we manage PE, it's all about risk stratification. So it's when you have someone that is coming in with hemodynamic instability, then this is a high risk with no questions. So anyone with cardiac arrest or obstructive shock, as defined here by blood pressure less than 90, or the need for vasopressors, or the evidence of end organ dysfunction, qualifies to be in a high-risk state. But the question is not about those patients, because those ones are usually clear and we know we can recognize them easily. It's all about those with less severe symptoms. So in those patients without hemodynamic instability, then we have to further risk stratify them by clinical imaging, lab, and presence of comorbidities or other aggravating conditions. And we know that the PE severity index score is probably the most important and well-validated score to assess the severity of pulmonary embolism. So these are the parameters of the PE severity index scoring. It includes age, gender, presence or absence of some of the clinical risk features like cancer, heart failure, pulmonary disease, and also vital signs like a blood pressure and a heart rate. There was an original version and there was a simplified version, and both are well validated to indicate the degree of severity. These are the risk stratification. So if you have 0 point, your 30-day mortality risk in the new model is 1%. However, if you only have 1 point out of these, which is not uncommon, then your risk of dying at 30-day reaches up to 11%, which is quite high. And all comers patients with STEMIs, all comers, the risk of mortality at 30 days is about 8 to 9 to 10%. We don't usually see PE as equivalent of a risk to, as we see that with STEMI. So this is from the most recent guidelines in 2019, and it classifies patients into high, intermediate, and low risk. And as we said, the high risk are easily recognized. The low risk are also easily recognized. I think the trick here is in those patients who have intermediate, even that the intermediate also can be classified further to intermediate high and intermediate low. And we do that based on, again, the presence or absence of clinical signs, imaging with echo, and also biomarkers with BNPs and troponins. The assessment of RV by imaging should be considered even in the presence of a low PZ score. So this is a class 2 and A indication. The question here is, maybe you can do a poll and see who would routinely ask for an echocardiogram for every patient with PE. Okay, even if they are low risk, I think that's still an important consideration here. A few questions is, when do we perform the echoes? If you have someone in the middle of the night coming in with PE, what time do you need to do it? Is it like right away, or you can wait until the morning? And if you do it off hours, who's going to read it? Is it the cardiology fellows, or is it the attending that is going to confirm the findings? And then what kind of detailed parameters would you go for? Do you just go for a regular TTE, or you just go for limited right-sided echoes, and how much you're going to do in terms of the detailed assessment of the RV? Again, these are questions that have not been answered very well in the guidelines. They just recommend doing a TTE, but if you go further into the details, there are lots of issues that can be addressed in these type of questions. Now, the guidelines say that anticoagulation should be initiated in all patients, and that's class 1A, or class 1C. And then for those patients who have high-risk PE, I think we have well-established evidence to say that thrombolytics should be administered. I think we will have a talk about surgical pulmonary embolectomy, and also we're going to have a few talks about the percutaneous catheter-directed thrombolytics. We'll leave that to there. So when it comes to thrombolytics, so they usually lead to faster improvement in pulmonary obstruction and thereby reduction in RV dilatation on echo. This is not without a price. So we have a rate of 9.9% rate of bleeding and 1.7% rate of intracranial hemorrhage. Not only that, not all patients would respond to thrombolytics, as 8% of those patients will have still evidence of clinical and radiological obstruction. Now, it's quite well established, thrombolytics for high risk. Now, the question is, what should we do for those who have intermediate risk? And I think this study, the PYTHO study, helped us understand this, or I don't know if it helped us, because it did not really, it gave us two conflicting messages. So it included patients with intermediate risk PEs, and they randomized them to thrombolytics versus no. And what we see here in the primary end outcome, you can see that death was lower in the T and K group, not statistically significant, but this came at a price of increased bleeding. So you have major extracranial bleeding, 6% in the T and K group compared to 1.2%, and also hemorrhagic stroke, 2% compared to 0.2%. So there was clear increase in the rates of bleeding in those patients. And this is the reason that we don't routinely or recommend giving thrombolytics for patients who have intermediate risk PEs. Now, after this study, the question was, maybe we should consider half-dose thrombolytics in those patients. Instead of giving 100 milligram TNK, we should just give a 50 milligram. And the rationale for that is you can maybe achieve a lower rate of major bleeding, and this 50 may give you some adequate lysis. And if you need to, you can also go for the top-up dose if needed. But this is not well studied in a randomized control trial, so all what we have to support this strategy is small observational studies and retrospective analysis. It makes sense in certain patients, especially those elderly with higher risk of bleeding, but it is not supported by randomized control trials, and thereby it is not, as of now, recommended in the guidelines. So we can see that the decision regarding treatment is a bit complex, and it is not a single person decision, and it should come from a multidisciplinary group, and this is this was the idea of the PERT team. So basically it is a multidisciplinary team from different specialties, individualized treatment plan to develop individualized treatment plans for patients with massive and submassive PEs. As we saw, we have multiple different options for treating those patients, and the decision should come from people with different backgrounds. So it started back in like the early 2010s in MGH, where the first PERT team was founded, and then it progressed into the development of the PERT consortium. And nowadays, multiple hospitals in the region have well-established PERT team. So what is the optimal structure of the PERT team? There is nothing called optimal, because it really depends on what are the resources that you have in your hospital. So it depends on the infrastructure that you have, the types of specialties, and most importantly also, as we saw yesterday, who is interested to join that team. So it could include people like interventional cardiology, cardiac surgery, ER, hematology, pulmonologist, and an interventional radiologist, to name a few. The PERT activation process, again, is variable by different hospitals, but basically it includes early identification of those patients, and then early risk stratification and early discussion to decide what's the best intervention or treatment for those patients. There are multiple different algorithms to streamline this process. And I think the message here should be, you should utilize or you should adopt the whatever algorithm that fits your hospital and your infrastructure that you have. But this is a common one where we can see that once acute PE is identified, anticoagulation should be started immediately. And then if there is any evidence of shock, then the patient goes right away into the left-hand side of the algorithm, and high-risk PE should be, or algorithm should be followed. If they don't have any of the immediate signs of hypertension, then further risk stratification should occur. And then again, the PERT team should decide where to go from there. Is there any evidence for PERT team? Yes, it's not a very strong because there was no head-to-head randomized control trials, but this study evaluated the outcomes of patients before and after the adoption of PERT team and demonstrated that there is lower risk of bleeding, shorter time to therapeutic anticoagulation, decreased deployment of IVC filters, and increased use of catheter-directed thrombolytics, and most importantly, decreased 30 days mortality. Again, not very methodological evidence, but it supports the observation that PERT team actually improves outcome. So the guidelines have adopted this and is now Class 2A recommendation to establish a multidisciplinary pulmonary embolism team in hospitals. And I would encourage all of you, if you don't have such a team in your hospital, to start thinking about it, as it's clearly associated with improved outcomes. And with that, I'd like to conclude and thank you very much.